Hi, everybody. Welcome. We're so happy you're here with us today. We'll get started in just a moment. I can see that there's a few colleagues popping into our waiting room. I hope that you have a glass of water handy, maybe a snack to keep you going through these next 90 minutes, but we're so glad that you're with us. We'll get started in just a moment here as we continue to let folks into our virtual room. And in the meanwhile, I'm happy to introduce myself. My name is Elizabeth Rumble. My pronouns are she and her, and I'm a senior workforce development specialist at the Denver Prevention Training Center. I've officially been in public health for about 7 years, but prior to working for a public health agency, I've spent many years out and with the community working on structural and social determinants of health. And I'm excited to be here with you today for this webinar and with my colleague Azul, who will introduce himself in just a few moments, and our amazing producer, Misty. Misty does have a P in front of her name, P for producer. So if you're having any tech challenges in today's webinar, feel free to private message Misty and she can make sure that you get taken care of. And we can imagine that there's folks on this call today from all over the Western region, maybe even beyond. I thought I saw somebody from Pennsylvania on our registration list. I'm from Philadelphia originally, so go Birds, glad you're here. But I would love for you to introduce yourself in chat to one another. Start by sharing your name, your pronouns, your role, where you're zooming in from. And tell Azul and I if you are working with a jurisdiction that is conducting opt-out HIV testing in an emergency department or urgent care setting. So put all of that into chat if you can. Feel free to scroll through chat, read those introductions of our colleagues on the call today, and let's get a sense of who is on this call with us. And wherever it is that you are zooming in from, we're glad that you're here to join us in understanding how opt-out testing can improve early detection of HIV and how it can improve linkage to care. We're also excited to discuss important considerations for your jurisdictions to help you get started in adopting an opt-out HIV testing program if you're not currently doing that in your emergency departments or urgent care settings. But before we jump into all of that, let's take a few moments to orient ourselves to this space and to this work. And Azul, if you can go to the next slide for me. Azul and I are here today on behalf of a CDC-funded capacity building assistance program for high impact prevention program integration. And this capacity building assistance, or CEBA funding, has 4 goals that you can see on the screen here. First, to reduce new HIV infections. Second, to increase access to care for persons with HIV. Third, to improve health outcomes and reduce mortality for persons with HIV. And then last, to reduce HIV-related disparities. And the funding that the CDC gives us accomplishes these goals through 4 separate components, which are national training, both through classroom learning and e-learning, such as modules like this, regional technical assistance, continuous quality improvement and sustainability for community-based organizations, and then marketing and administrative support for the CEBA provider network. Finally, the CEBA programs seek to address health disparities and the social determinants of health and to provide culturally competent and responsive HIV prevention services. So let's go to the next slide. I love this map, friends, because it really encompasses all of the US and it shows no matter where you are, we have a CEBA provider for you. So as you can see on this map, there's 4 regions: the Northeast, which is in this teal color, the South, which is in red, the Midwest in yellow, and the West in purple. And like the other CEBA providers listed here, we are funded by the CDC to provide regional technical assistance. So Azul and I are in this purple region, but again, no matter where you're from today, we are glad you are with us on this call. Let's take a look at what this looks like in the West though. Azul, if we can go to the next slide. Here in the West, there's 3 technical assistance providers: the Denver PTC, the San Francisco Department of Public Health, and the California PTC. And each West TA provider is assigned a specific track, and each track has specific responsibilities. So at the Denver PTC, as a Track A provider, we work with organizations conducting HIV clinical testing and prevention for persons living with HIV. Our partners at the San Francisco Department of Public Health provide TA to organizations conducting non-clinical HIV testing and prevention for HIV negative folks. And finally, the California PTC provides TA on integrated HIV activities and structural interventions, such as condom distribution or syringe service programs. And guess what, friends? All of these programs are free. All of this assistance is free. So if you are Zooming in and you say, well, I want some TA, I want some of these free services, there's two ways you can do that. The first is asking yourself, am I a federally funded or directly funded jurisdiction, like a state health department or a county such as LA or San Francisco? And if you are, you can enter a request on this website. And I think we can paste this into chat for you as well. www.cdc.gov/CTS. And if you're not a directly funded jurisdiction or organization, you can contact your jurisdictional health department and ask them to submit this request on your behalf. And Ty, I see that in the chat. Thank you for dropping that in there for us. We would love to hear from you. We love meeting folks from our West region and providing these services. As for us here in Denver, next slide, Azul. We're with the Denver PTC. We were founded in 1979, and we provide innovative training, consultation, and information to healthcare professionals and their organizations. The Denver PTC has a unique advantage of being part of a public health institute, which is the Public Health Institute at Denver Health, which resides in a large comprehensive healthcare system called Denver Health and Hospital Authority. So we are part of Denver's safety net system. And being part of a medical system, a hospital, really has advantages for us as we think about how to offer these webinars and do things like today's training around opt-out HIV testing in emergency departments. Our program is supported by a cooperative agreement with the CDC, and our mission is to build the capacity of health professionals and their organizations through responsive training and consultation. We do this by building collaborations through relationships, by fostering a culture of excellence, and really by striving for equity in all that we do. So that's a little bit about us. But before we start our discussion of opt-out HIV testing in frontier emergency departments and urgent care centers, we do want to review a couple important housekeeping notes. So friends, this 90 minutes that we have together, it's really meant to be an interactive webinar, including time for discussion at the end. And during the webinar, you might find yourself with a question. And Azul and I love questions. We love and encourage those questions. We are here to learn and to grow together. But we do ask when you do have a question that you drop that question into the chat box for us. That way we can keep track of those questions as they come through. And we'll be sure to revisit those questions at the end of the webinar in the Q&A segment. Also, you know, I am the first to admit that sometimes questions stump me. So if you ask a question and I don't have an answer for you, we're going to work hard to get you an answer, and we'll be sure to follow up with an email response when we do have that correct answer for you. All of the questions from today's webinar will be posted on our website at a later date. And Azul and I want to thank you for your participation in this discussion. We know that everyone has something to learn and everyone has something to teach. So don't be shy in participating and sharing your thoughts and asking those questions. This really is innovative work, my friends, and we're excited to trailblaze in this space together. So with these housekeeping notes in mind, let's move ahead to our discussion for today, opt-out HIV testing in emergency departments and urgent care settings in the Western frontier. And we're going to cover a lot today. By the end of this webinar, you'll be able to identify successful HIV testing and counseling approaches in frontier jurisdictions, describe the impact of opt-out routine HIV testing in EDs and UC settings, and recognize the resources that are required to implement opt-out routine HIV testing. Additionally, our hope is that you'll have the skills needed to develop innovative and effective opt-out HIV testing strategies in your local context. So these strategies are intended to reduce the rate of undiagnosed HIV infection and to bridge the gap of disparities among underserved populations. After these short 90 minutes together, we hope that you leave feeling empowered and informed about your ability to make a positive difference in your community, and that you have an increased understanding of how your efforts can make an impact on reducing HIV transmission in frontier jurisdictions. So you've heard quite a bit from me in this intro, and I've alluded to Azul a couple times. Azul, I would love to turn it over to you to share your introduction and then to take us through our first section of this webinar.
Great. Thank you so much, Elizabeth. Good morning, everyone. Azul Del Grasso, he, him, el pronouns. I've been with the Prevention Training Center for 7 years and in the field of HIV for 25 years. So we're excited to have you here this morning as we dive into our webinar. All right. So this webinar is going to provide an overview of the rationale for HIV screening in frontier jurisdictions. We're going to discuss the current landscapes around HIV testing. We're going to explore some of the data, the prevalence, incidence trends, and review evidence-based approaches to increase access and uptake to HIV testing services. We also want to examine public health implications, ethical considerations, best practices for working with underserved populations. And finally, we're going to discuss strategies to ensure HIV screening is incorporated as part of a comprehensive public health model and response in these areas. So our hope for today is to gain some insight into current challenges, look at opportunities for HIV screening in frontier jurisdictions, and leave with some recommendations on really how to optimize your testing programs. So what is a frontier area? This is a great map that Elizabeth and I came across, and it really kind of highlights what some of these frontier areas are. So the definition of frontier in general, frontier areas are sparsely populated rural areas, which are isolated from population centers and services. And unfortunately, there's not a single universally accepted definition of frontier. Definitions of frontier areas for state and federal programs vary depending on the purpose or the project or the funding that's being designated for those areas. So while it's often defined as counties with population density of 6 or fewer people per square mile, this is a simple definition and does not consider other important factors that may isolate a community. So these definitions can be more complex and by address isolation, considering rural distance in miles to services. A 2016 policy brief considered in classifying an area of frontier area including population density, distance from a population center or specific service, travel time to reach a population center or service, functional association with other places, availability of paved roads. It even takes into consideration seasonal changes to access services. And so then in this context, we're looking at a density of between 12 and 20 persons per square mile. And with that distance, we're looking at between 30 and 90 miles to services. And then service time to service or market areas, again, 30 to 90 minutes. So let's do our first poll question. Misty, if you could pop that up. Are you here representing a frontier jurisdiction or region today? And I see some answers coming in. Give it just a few moments. All right, I think we have majority. Misty, could you share those results? And 69% is, yes, I'm from a state with frontier jurisdictions, followed by I'm not from a frontier jurisdiction or state or frontier area. And then 12% of you are from frontier jurisdictions. Wonderful. Thank you for joining us today. So in identifying service gaps in Western frontier jurisdictions, we know that they face such challenges such as limited access to healthcare, difficulties maintaining a healthcare workforce. There's higher costs due to per patient due to lower volumes of patients served. And then there's also seasonal variations in demand. Additionally, these regions lack public transportation options and sometimes fair weather conditions for travel. We also see frontier jurisdictions at a higher risk for substance use, suicide, obesity, cigarette smoking, and death from unintentional injuries other than in rural areas. So these issues require special attention due to their unique nature and location. So let's quickly review the national HIV surveillance data from CDC. As we think about how to end the HIV epidemic, emergency departments are often the front door or entryway into prevention and care services for many communities. Emergency departments are essential in this effort to meet our goals of increasing the number of people in care, retained in care, and virally suppressed. And so since 2016, the rates of diagnosis have been declining. So we know with this, the number of people living with HIV is 1.2 million. It's estimated the number of HIV diagnoses per CDC in 2020 was 30,000. The percent of folks living with HIV who don't know it is still at 13% as of 2020. And then the percent of people diagnosed with HIV who are virally suppressed, we're at a high of 65%. And so this infographic on the screen represents the areas of new HIV diagnosis in the US, dependent of areas by region. And this is as of 2020. So this should be interpreted as with caution due to the impact of the COVID-19 pandemic on access to HIV testing, care-related services, and case surveillance activities in state and local jurisdictions. But understanding the places and populations that are most affected by HIV allows the federal government to allocate its resources to geographic areas where they are needed the most, while still supporting a basic level of HIV education and prevention for everyone across the country. And so now that we've reviewed some of the healthcare challenges in frontier jurisdictions, as well as some HIV prevalence data, including the estimated of 13% of folks living with HIV who don't know they have it, we want to define testing options so that we can build a shared understanding about how to approach HIV testing in jurisdictions with emergency departments or urgent care settings in frontier areas. So in HIV testing, there are two forms of testing to consider, either opt-out or opt-in. Opt-out HIV testing is a type of testing where the individual is informed that an HIV test will be performed unless they declined. With opt-in testing, an individual is offered an HIV test and has to accept the test before it will be performed. So in the 2006 revised recommendations for HIV testing of adults, adolescents, and pregnant women in healthcare settings, the CDC recommended the opt-out approach to testing for all adult and adolescent patients in healthcare settings, including pregnant women. And because of this recommendation, this webinar will focus on an opt-out approach. And it should be noted that opt-in and opt-out describe only a way of consent is obtained and can be applied in all testing approaches. So diagnostic, targeted, non-targeted. Each healthcare organization can make these decisions on what level of screening they would like to do based through their own lens and how they know their community. So I like this graphic on the right side of the screen because it shows how narrow screening can be. With diagnostic only, it can be broad as you want it to be through universal screening. So let's define each of these rings in the circle. In the center, we have a diagnostic screening, which is when we screen an individual in the context of their clinical signs and symptoms. Next is targeted testing. And this is when we perform an HIV test for subpopulations of persons at higher risk, typically defined on the basis of behavior, clinical, demographic characteristics. So there would be a need for risk factor questions to inform this type of screening. And the last is non-targeted testing, also referred to as routine or universal testing, which entails HIV testing of all patients attending a clinical service, irrespective of clinical features, demographic risk factors. So a meta-analysis study was designed specifically to compare opt-in and opt-out diagnostic strategies and included only randomized and quasi-controlled strategies. The study wanted to determine which type of testing, either opt-out or opt-in, yielded more people being tested. Well, the study found no statistically significant difference in the rates of HIV detected. More people were tested with opt-out testing, reflecting a higher acceptance rate. And this means that more people will be diagnosed and linked to care. As you can see from the bottom right of the slide, 44% of the people were willing to be tested in an opt-out arm versus 19% in a standard opt-in arm. And these findings tell us that when the care team offers an HIV test as a standard part of care, rates of acceptance are significantly increased. And so this slide images comes from directly from the Primary Care Development Corporation. And this is a course that can be accessed by registering on PCDC's website. And so you can pop this into the chat, but what communities might use EDs for their healthcare folks?
All right, colleagues, the question is in the chat. What communities might use the EDs for their healthcare? So we have rural, people are thinking about this, homeless folk, uninsured, etc. Communities without a lot of primary care physicians, people without insurance, people without medical homes, communities that do not have access to PCP for various reasons, uninsured, underinsured. The responses are rolling in, Azul.
Great, thank you. Appreciate all those responses. And so, opt-out routine HIV testing is beneficial in ED and UC settings because it helps to reduce disparities in accessing healthcare for racial and ethnic groups. Many frontier jurisdictions give access to marginalized communities, and they know that these communities face a number of barriers when attempting to access healthcare. So as we see in the chat, you're nailing it right on the head of the nail. So in doing this, we know that these are folks who are underinsured, people with substance use disorder, people with mental illness, people experiencing homelessness, and simply folks with just no primary care.
There's one additional response in a couple additional responses, so I just want to read them.
Sure.
Undocumented immigrants, folks that do not use primary care as a cultural norm, and folks who want care at hours that primary care settings are not open.
Great, thank you for that. And thank you for all the responses. And so when we think about the prevalence of HIV in emergency departments, we're going to show this study, but this was a retrospective study conducted in the Memorial Healthcare System in Hollywood, Florida. HIV test was offered as an opt-out basis to ages 16 years and older for folks presenting to the ED. of the Memorial Region Hospital. And this was between July 2018 and August 2020. But during this time, a total of 105,000 folks, or 53% of their patients, of the 196,000 EDU patients were eligible for HIV testing, and 39,000, or 37%, completed the HIV test. And of those tested, 206 of those patients tested positive, with 54, or 26% of those folks who were newly diagnosed. And so when we think about that percentage of folks with HIV infections who are not engaged in HIV care, we know that 75% of those were successfully relinked or linked into care. And so we saw engagement in care increase from 50% to 80% post-testing. And so this data demonstrates the value of opt-out testing in EDs for identifying both newly infected patients and drastically increasing engagement in care. EDs have a significant role to play in ending the epidemic. And so EHE, or ending the epidemic, and emergency departments have an important role to play in this process. Opt-out HIV testing in EDs can help identify newly infected patients and drastically increase engagement in care by providing a convenient, accessible point of entry into the healthcare system. This data also demonstrates the value of opt-out testing in EDs for identifying both newly infected and increasing engagement folks with care. And by offering the opt-out model, EDs can be a critical gateway to support those affected by HIV and help reduce disparities in access in early treatment. And this data also shows that it's evidence to inform policy decisions by expanding opt-out routine HIV testing in healthcare settings. All right. And so CDC recommendations for routine opt-out testing. So in healthcare settings, HIV testing can be a critical diagnosis in treating those affected by the virus. And the importance of routine opt-out HIV screening cannot be understated, as it helps to identify high-risk individuals who may have not known their risk or otherwise gone undiagnosed. So by removing the stigma associated with HIV testing, this strategy also fosters earlier diagnosis and treatment by reducing the risk of transmitting the virus to others. And so we think of populations or factors where folks are at risk. These are people under 20 years of age, women, including pregnant women, other underserved communities, non-urban dwellers in low incidence areas, and heterosexual men and women who are unaware of their risk status should also be screened regularly so that they can be diagnosed and treated early. Routine opt-out screening is a cost-effective way to detect HIV in early stages, and it can be easily more managed with treatment. Healthcare providers have several justifications for conducting routine HIV testing, including the fact that it is a serious health disorder that can be detected before symptoms developed. There are reliable and inexpensive tests available, and those who are diagnosed receive treatment early on gain years of life. Additionally, the screening costs are reasonable compared to the potential benefits. So healthcare providers should strongly consider incorporating routine opt-out HIV screening into their practice. Early diagnosis leads to earlier treatment, which can significantly improve patient outcomes while reducing transmission rates. And by doing so, we can work together to fight the spread of HIV. All right. So in the chat, please tell us what you think of some of the benefits of routinizing HIV testing.
Coming in fast, also reduced stigma, creating a norm, removes biases.
Excellent, excellent answers.
There are more thoughts coming in. I can feel it.
Great. Well, you're hitting the mark, so the benefits of routinizing HIV testing, it encourages testing for all people. And this is 16 to 64. It moves beyond risk. It destigmatizes, as you've mentioned, HIV and HIV testing. It normalizes routine conversations about sexual health. and identifies HIV infections earlier. And it supports prenatal patients as well in this process. So thank you, everyone.
And there are two more responses I would
Sure.
like. More immediate care. It's free testing.
It's free testing. Excellent. Thank you.
Increases the number of folks tested.
Great. Yeah, and so as someone just mentioned for immediate care, the importance and impact of timely HIV diagnosis. So we know that early detection and treatment of HIV and antiretroviral therapy, ART, can help people with HIV to live longer and healthier lives. We know it reduces the risk of transmission to others. And then we know that providing early tests in EDs and UC clinics, we can reduce the chances of misdiagnosis and ensure that these folks who need treatment receive it as soon as possible. And this is particularly important considering marginalized and vulnerable populations who may be less likely to access regular health care. And so this bar chart on the side shows the percentage of persons with HIV infection and the percentages of folks transmitting along the continuum of HIV care in the United States. And this is going back to 2016, but this data shows us that it's approximately 80% of new HIV transmissions are from persons who don't know that they have HIV and they're not receiving regular care. And people with HIV who are aware of their status should be prescribed ART by achieving and maintaining a suppressed viral load. And we know that that's under 200 copies, so they can remain healthy for years. ART is now recommended for all people with HIV, regardless of CD4 count. And studies show that the sooner people start treatment after diagnosis, the more benefit they will have from ART. So early diagnosis followed by prompt ART initiation reduces HIV-associated morbidity and mortality and greatly decreases HIV transmission to others and may reduce the risk of serious non-AIDS related diseases. And so with that, I'm going to pass this back over to my colleague, Elizabeth.
Thanks so much for that, Azul, and for taking us through this overview of the unique challenges and opportunities that really exist within frontier jurisdictions. So now that we know a little bit more about the benefits of adopting this opt-out universal screening approach to HIV testing, we want to take a look at some of the considerations regarding resources that will help you build organizational capacity for opt-out HIV testing. Organizational capacity really is critical for the effective functioning and sustainability of emergency departments and urgent care centers. And this looks like clear resources, clear processes, systems, structures, things that enable ED or UC staff to deliver timely and efficient HIV testing. Building organizational capacity requires a comprehensive approach that takes into account all aspects of the organization, from staffing levels to data management to communication protocols. So let's start with an overview of the key resources for this 101 course that we've identified that will help you build your organizational capacity within an emergency department or urgent care setting. Now, as I just mentioned, and Azul, if we can go to the next slide, communication protocols are such an important consideration when you think about how to build your organizational capacity. And communication protocols first need to consider how we talk to our patients about HIV testing. Specific to this webinar, we want to highlight the importance of understanding consent for testing. And the consensus among healthcare providers and legal professionals is that HIV testing should not require separate written consent. Instead, general informed consent for medical care that notifies the patient that an HIV test will be performed unless the patient declines that test should be considered sufficient to encompass informed consent for HIV testing. This opt-out form of providing information about HIV tests has been proven to reduce the stigma associated with being tested for HIV. It results in increased testing rates, and it helps ensure individuals know their status. Additionally, it eliminates the need for separate written consent forms, which can sometimes deter individuals from seeking out these needed services. So understanding aspects of your state's laws related to consent and counseling can help ensure individuals are well informed before receiving or declining that HIV test. State law should reflect CDC's recommendations for consent and counseling to support routine testing and ensure individuals can make those informed decisions about their health. And we know that there's going to be challenges if you're trying to stand up an opt-out testing program in a ED or urgent care center that hasn't had it before. Perhaps one of the biggest challenges, other than funding for tests or test kits, is a challenge around staffing models. So Zul, if we can go to the next slide. Friends, if you've ever stepped into a busy emergency department, you know that there are many acute injuries or illnesses that require immediate attention, and that any time dedicated to one aspect of patient care might come at the expense of some other vital functions that EDs perform. So a resource requirement in building your organizational capacity is thinking about the staff who are involved in implementation, and specifically at what stage are we obtaining consent for HIV testing, at what stage is the test performed, and who's involved in each action. Staffing considerations should include who records the results on the chart and things like who tells the patients about the results of the test. In some organizations, the person that shares the test results might be different based on whether or not it's a positive or negative test. In our research and our conversations, we learned that there's many different models that are currently being evaluated. And friends, if you came here hoping to hear the one right answer on how to do this, I'm here to tell you that I don't have one right answer for you right now. We are still reviewing the research, but our recommendation to you is that you look at your own processes within your own jurisdictions and settings, and you develop your own staffing model based on what makes the most sense for you. We do have a couple options we want to propose to you for you to ponder, and it includes things like physician-based ordering and screening. Maybe that takes part of the routine triage process, or there's other models that might involve patient advocates and social workers. But if you're in a very frontier area, you might not have a patient advocate in your setting. So we share all of this to say, as we go through these settings and considerations, think about what would work best for you, for the staff that you have, whether or not they have previous medical training, if they're going to require more oversight than medical staff who might already be serving in an ED, and think about the places in your settings, in your jurisdictions where HIV testing can occur. Again, there's no right answer. As long as it makes sense for you, maybe that is the right answer. And there's going to be advantages and disadvantages to any setting. So let's explore 3 potential settings in a little more depth. And the first one that we have for you on the next slide is the place that patients first come into, and this is registration. So offering HIV testing at registration has numerous advantages. First, it's offered and named at the individual's very first entry into care. And when it becomes standardized and it's part of the registration process, studies have shown that it does result in higher offer rates. So a pro to this setting is that it distributes the process amongst multiple roles, such as registration staff or triage nurses, and it isn't the sole responsibility of one person to uplift. But as you can imagine, there's some disadvantages to offering testing in the registration process. First, if this slows down the registration process, additional resources or staff might be needed, especially as we're thinking about triaging patients. The registration desk is also in a very public space, so it might result in lack of patient privacy. And some patients might need translation services, and maybe these services won't be fully available at the front desk. Last, a disadvantage of this space is knowing that registration staff often don't have a medical background. So this could put staff in stressful situations based on the patient's reaction to this offer. Maybe patients feel disrespected when HIV screening is offered, or maybe they have specific medical questions that are out of scope that they couldn't answer. So advantages to this space, disadvantages to this space, but one of the 3 settings that we want to offer to you for consideration. The next setting, and we'll go to the next slide, of where this HIV testing can be offered is in the waiting room. So if the ED or urgent care is particularly busy, there's going to be some natural downtime that happens in this waiting room as visits are triaged. And from the research that we've seen, offering testing in the waiting room generally results in higher acceptance rates for testing. But like the registration area, there are disadvantages to this approach too. Now, in many settings, there might be no resources that exist in that waiting room, whether it's staff, whether it's technology, whether it's something else. There's no resources available to support this process. It can be a burden to try to drum up those resources to start it in this space. And for this approach to be successful, there might need to be a self-service platform or a dedicated testing service space. And we know that many organizations don't have the capacity to implement this. And then last, like at registration, patient privacy can be a major concern with this strategy. And the last distinct setting that we want to present in this webinar today is the treatment room. So Zul, if we can go to that next slide. Before joining today's webinar, perhaps this is where your mind automatically went when you were thinking about the places that testing could be offered. And that's because we know most of the screening for patients naturally occurs in the treatment room. One of the biggest advantages to offering testing in the treatment room is that it will likely be done by a nurse or a provider. And when providers are talking about standard labs or tests that they recommend, research shows higher acceptance rates for HIV testing, especially if it's grouped with other tests. If resources are available, a counselor-driven model could be used in the treatment room. And while we name nurses or providers as the main advantage in this setting, we also know that providers and nurses are limited by time constraints in each visit. This is a very real thing, my friends. So this approach does have disadvantages in that there could be higher priority issues to address in the ED or UC setting, and that this approach might add time to the visit. So thinking through all three of these approaches, and I think Azul had named this earlier, there is a course that I'll share in chat momentarily. It's a great course by our partners at the Primary Care Development Corporation, or PCDC, and it's free, it's easily accessed, and it's a self-paced study that goes into each of these three settings a little more in depth. But as I get that link ready for you in chat, I do have another poll that I want to launch. So Azul, if we can go to that next slide, and Misty, if you can help me get this poll up. Now that you've heard this very basic introduction to these three settings, and you're thinking about the emergency departments or urgent care centers in your jurisdiction, what testing location would be most feasible for you? So I wish there was a select all, because maybe it is all three options, but instinctually tell me, is it A, the waiting room? Is it B, this registration process? Is it C, the treatment room? Or is it D, not sure? Again, no one right answer. We know that settings and resources will be very different across the country, but tell us in chat what you're leaning towards. I'm seeing these results come in quickly. Love to get a few more responses, friends, and it's okay if you're not sure. That's an option too. Feel free to choose that. But tell us what setting would be most feasible when considering where to offer testing in your jurisdiction. And so I'm pretty happy with this poll participation. Why don't we end the poll? Misty, if you can help us with that and share the results. So seeing a couple things across the board here, right? A couple of folks saying the waiting room, some folks saying registrations, the majority, half of our folks saying the treatment room, and about a quarter saying not sure. So if you feel comfortable, I would love for you to add in chat which option you picked. If you picked registration, if you picked treatment room, if you picked not sure, tell us what option you picked and tell us, what came to mind that informed that decision in this poll. And that will help us in our dialogue at the end of this course to think through what resources exist for you. Ty, I saw you come off mute. I don't think we'll read them out now, but I'm just curious to hear what you're thinking about and thinking where it would be most feasible. So drop that in chat for us. We'll get to that at the end. And then friends, there's one more important resource consideration that Azul and I want to draw your attention to, and that's the use of electronic health record systems if they're available. So we know it's not available in all areas, but if your jurisdiction does have electronic health records, there can be an option to automate the process that prompts for testing. So it's not just in somebody's mind that, oh, I should be ordering for this as well. And we have an example of how opt-out HIV testing can be a routine part of a patient visit. This example comes to us from Boston. It was enacted in October of 2013 at the Beth Israel Deaconess Medical Center, which is a large academic medical center. And they enacted a passive electronic health record reminder for HIV screening for all patients who are age 13 to 65. And this reminder was really simple, friends. It just said HIV antibody. It was in red letters on the homepage of each patient's record, and it popped up alongside other clinical reminders. And if the HIV test was performed, the reminder disappeared automatically. And if a test had been done outside of this medical institution, or if the patient declined testing, the practitioner could enter this information into the EHR and it would make that reminder disappear. But what I love about this slide is some of the data that we have that shows how beneficial it can be to really automate this process with an EHR. So before the reminder was added to the EHR, only about 15% of patients who had not been previously screened received an HIV test. And at this practice, on average, that was coming to about 254 HIV tests being performed each month. Now, pre-reminder data also showed this trend toward lower testing rates in older patients. So if we're looking at this bar chart, the before numbers are the darker color on the bar chart, and then the after numbers are the white bars on the chart. But you can look at the HIV testing by age. And you can see here that only 9.7% of folks who were 46 to 65 years old were receiving testing, compared to 15.9% of 36 to 45-year-olds, 23.1% of 26 to 35-year-olds, and 22.5% of patients 25 years old or younger. And this pre-reminder data also showed us that women were less likely to be tested. So on average, women were being tested at rates of 14% compared to 17.3% for men. Now, after this process was automated and the reminders were added to each electronic health record, 30.7% of patients who had never been tested for HIV received an HIV test. And this represented a 2.02 relative risk of screening compared to the pre-reminder period. And the average number of HIV tests per month completed in the practice went from 254 to 462. So this increase in testing was observed in all patients, in all ages, gender, race, language, income groups. And one of the most striking effects showed that although patients aged 46 to 65 were least likely to be tested pre-reminder, the reminder had the largest effect in this older age group, increasing the proportion of patients tested from 9.7% to 27.2%. Also notably, the reminder equalized rates of testing between genders after implementation, resulting in a 31% rate for both groups. So just, fascinating data that really points to technology being our friend in this space. And if we can automate processes, thinking about that as a resource consideration. I've got one more example of how process automation can have a positive impact on testing, Azul. If we can go to that next slide. This example comes from a study conducted at a level 1 trauma tertiary care academic medical center, emergency department in West Virginia. Try saying that 5 times fast. But this was really aimed to increase screening for HIV and hepatitis C. And at this medical center, the EHR would display a best practice alert, or a BPA, to alert providers and staff if a patient was eligible for screening based on their age cohort or other risk factors. And the study found that the BPA appeared 2.8 times on average per patient for HIV screening and 2 times per patient for hepatitis C. And of those eligible, 34% of patients agreed to be screened for HIV, 29% agreed to be screened for hepatitis C, and it significantly increased screening rates. So prior to implementation, only 300 HIV screenings and 300 HCV screenings were conducted in the ED in about a year's time from July 2015 to July 2016. And the results are here on the screen related to HIV screening. Was almost a 2,300% increase over the course of 12 months. So again, EHRs are a great resource to consider if they are available within your jurisdictions. And I've seen a headline in Google about the problems with AI. So we don't want to discount the fact that staff are super important in this process too, right? It's not just about the EHRs, but it's about creating staff buy-in as well. And we've discussed many resources so far, including patient flow of where testing can be offered or the use of these electronic health records. But really the last resource that I want to highlight is the staff that exist within these emergency departments and urgent care centers. So HIV testing in emergency departments is crucial for the early identification and treatment of HIV patients, particularly in high prevalence areas where patients might not have access to primary care. And we alluded to this earlier when Azul was talking about the opportunities and the challenges within frontier areas. We know that access to primary care is a big challenge in the Western frontier. But for this to be successfully implemented, staff buy-in needs to be established. So we have a 6-step model on the screen here of how we propose obtaining staff buy-in. And friends, it really starts with acknowledging the paradigm of infrequently ordering HIV tests on patients other than those that we see with occupational blood exposure in ED and UC settings. So we would advise that you consider using existing data, maybe from HIV reporting, to showcase the current number of HIV tests that are provided in the emergency department. And to help with this change, we recommend highlighting the potential benefits of screening in an ED setting. Now, emergency physicians play a vital role in implementing an efficient screening process that minimizes patient delay. And we want to highlight that importance of early identification and better treatment outcomes for HIV patients. In addition to highlighting these benefits, we want to have an open conversation with staff about their concerns in implementing a testing program. So we recommend inviting staff to share those concerns about capacity or efficiency. And, not just to share just for the sake of having this open forum, but really to share and to hear those comments, that feedback, those concerns, so we can create a more meaningful workflow and process that staff feel like they were brought into and a part of instead of something being pushed onto them. We also want to provide frequent feedback on program performance. So this might look like sharing data about linkages to care that might not have happened without access to this testing. It could also include sharing among physicians to develop a consensus on how to best tackle this issue and inform preliminary positive patients. So the data matters, and it will help with that continued buy-in. And finally, it's going to be important to hear from staff who will be involved in the HIV testing to continue to develop buy-in. Now, whether this occurs in a huddle or a team meeting, it will be important to present the model for HIV testing and hear from staff about any perceived barriers or concerns and address those before the program is started. So creating staff buy-in, super crucial aspect of this program. So with all of these considerations in mind, Azul and I are excited to share with you a case scenario for our frontier town, Tyville. And Azul, I'd love to turn it over to you to walk us through this case scenario.
Great, thank you, Elizabeth. I really appreciate you discussing some of those important considerations for developing opt-out HIV testing program in an ED or UC setting. So let's examine what it looks like in a frontier jurisdiction. This is a case scenario that we created. And to our knowledge, no frontier jurisdictions are conducting opt-out HIV testing in their EDs or UCs. So our example is meant to stimulate thought and conversation about how these foundational components should be approached. To talk about this, we're going to introduce you to our fictitious city, Tyville. a small frontier town that recently started doing opt-out HIV testing. And to tell you a little bit about Tyville, it's located in a remote area with limited healthcare access. The population's median age is 37 years old, with a high concentration of immigrant and refugee communities. There are very few local providers available in Tyville, although there is one emergency department that residents on average spend 1 hour driving to if they are in need of services. And so this lack of resources makes it difficult for residents to access necessary care and for health authorities to execute effective public health strategies and campaigns. So right now, Tyville is experiencing a local increase in HIV and has heard about opt-out HIV testing. Staff from the health department overseeing the Tyville jurisdiction reached out to their SEBA provider to schedule a meeting to discuss the increases. The staff at Tyville's emergency department met with SEBA providers to discuss a few program options, such as EMRs, billing structures, and financial resources. The Tyville ED was fortunate enough to have an electronic health record system already in place. And then looking at the data from other health systems and considering the many needs of patients who travel great distances to receive care at the ED, the staff decided to build the best practices alert into their EMR so that physicians were reminded to test for HIV. And then billing structures also play an important role in providing access to HIV testing in Tyville. The town has worked hard to ensure that those who need care can get it, regardless of their ability to pay. And this is also to accommodate this, they worked with their state health department to determine a billing structure for insured, uninsured, underinsured patients. The structure included billing insurance companies for tests when insurance was available, and utilizing free test programs from their state health department for uninsured and underinsured patients. The staff are also working to apply for funding next year through a foundation to help cover some of these costs. So this was Tyville's commitment to providing access to HIV testing is commendable. And they set up a very robust EMR, billing structure, and financial resources. They also have a set of strong examples on how communities can better serve those in need. And so think about their program staff. So with billing and EMR processes determined, the Tyville administrative team next move was to ensure that they had a program champion. And so a champion is someone who has the knowledge, skills, and passion necessary to help manage a complex operation. It's important to have a team champion when implementing any program, but especially with opt-out routine HIV testing in the EDs. This champion knows the benefits of early detection and available resources for testing and appropriate follow-up care. They can serve as a point of contact for questions and concerns, and they can also educate other healthcare providers and patients coming into the system. And they also ensure that the program meets its objectives. They also help ensure the appropriate treatment is available for those who test positive and facilitate a strong referral to HIV specialty care when needed. Ultimately, having a team champion to oversee and coordinate the implementation of an opt-out routine HIV testing program will help maximize the program's efficiency and effectiveness for reaching its goals. In Tyville, one of the nurse practitioners gladly volunteered to serve as a champion to the program. And this nurse practitioner had personal family connection to HIV and spoke with conviction and with passion about educating others in ED settings and why early detection mattered. The champion also worked with their SEBA provider staff to think through all the roles necessary to implement opt-out testing, including assuring follow-up for people who test positive. This included assigning roles to laboratory technicians, nurses, physicians, and administrative staff. And then thinking about limited resources within the Tyville ED, it was determined the work could be best distributed among medical team by having nurses responsible for receiving informed consent and administering the test. If the test came back negative, nurses could also share those results. Physicians played an important role in this process by explaining that HIV tests are recommended in routine lab work and would also be the ones to share the results if the test came back positive. Lastly, because the Tyville ED was limited in staff and linkage to care program did not exist in this facility, administrative staff were brought in to help connect with the state health department so that state disease intervention specialists could do follow-up with all positive tests. And so in this, we thought about a distributive workflow system that has been put into place to ensure testing process runs smoothly and efficiently every step of the way for the patient. So in hearing about people who are involved in the process, let's see what the program flow looks like in Tyville ED. The program flow starts with the patient experience. Tyville ensured that each decision made regarding testing process was prioritized, patient-centered, and above all, they wanted those coming into the ED to have an appropriate, effective, and efficient experience. And of course, providing a successful HIV testing didn't end there. This also was comprehensive follow-up plans were put into place, including those who tested positive to care and providing post-test counseling if needed. For those who tested negative, they received education on HIV prevention, transmission, in addition, access to treatment and care if needed. So as you can see from the screen here, the patient will come into the ED. HIV test is offered. If they say yes, if the offer is declined, missed opportunity. But if the HIV test is completed, if it's positive, they're linked into care. And if negative, referred to PrEP services if appropriate. And so this slide shows how physicians discuss an HIV test with all patients, making sure that everyone received proper information about the test and any potential risk it posed. The physician also made sure that they had enough staff capacity and EHR systems to efficiently provide tests for every patient who needed and wanted one. Tyville determined to take care of its citizens by providing them with thorough testing services, no matter their situation or how much time they had available. And this is a commitment that came from leadership, and it's a testament to the town's dedication to the health and well-being of its people. So again, in Tyville, we know that resources are limited. And while there is one emergency department, but there are no community-based organizations who work specifically with LGBTQ populations. Luckily, a clinic in the next county over often sees patients for primary care. The Tyville ED recognized that creating a partnership with this clinic and the state health department, that they could have an efficient linkage to care program, which is critical to patient success. So in this, the Tyville ED, supported by their SEPA provider, established an important partnership with that clinic. The team worked together to develop culturally appropriate outreach materials for the location population and provided clear information about HIV testing and counseling options. They also trained providers on best practices for delivering HIV services. And this is ensuring that all individuals receive the care that they need. So, thanks to the concerted effort and the collaboration between so many different groups in Tyville, they had success with this. And so, thinking outside of Tyville, we've listed a number of processes and ideas for EDs or UCs should consider when establishing an opt-out HIV testing strategy. There are other considerations, including external partners or have established best practices that we'd like to highlight before we move into questions. And so we know that, leveraging community partnerships is key in this. It's an integral to success in implementing an opt-out routine HIV testing in frontier jurisdictions, like we discussed in Tyville, and working with the clinic in a county over. But by working with local healthcare providers, clinics, hospitals, and other organizations within the community, we can ensure that everyone has access to the necessary resources for effective HIV testing counseling. We know that this also applies to conducting in-reach and outreach activities. Having on-site information can increase public awareness of the importance and availability of opt-out testing and encourage people to take advantage of it. And in the example of Tyville, we discussed that Tyville created culturally responsive materials that were relatable to the folks in their community. We know a big part of this is it's good to develop and maintain rapport and credibility with clinics. And so perhaps it's taking a visit or a drive to that clinic at the county over and building those partnerships versus just having a phone call or cold calling, as we say. And we also want folks to think about providing referrals. Referrals should include information on accessing medical care, support services, and any other resources in the local community. We can also think about virtual resources as well when thinking about frontier areas. So it's also important to know that people receiving referrals have the right to confidentiality and privacy. And this ensures that those tested feel safe disclosing their status to their healthcare providers and accessing any other necessary services outside of the ED. And we hope that this bridges any gaps between HIV testing and care services in frontier jurisdictions. So, we'll close on this. We want you to think about some initial steps, right? And so, we call the routine opt-out testing is ROOT, but it's routine testing for everyone, regardless of age, gender identity, or sexual orientation, who presents in a medical setting. And we recommend 13 to 64 years of age. So your initial steps: find your champion, consider changes needed to the medical record system. What's your current ED triage mechanism? And how do you place HIV opt-out question within the intake process, whatever that looks like in your setting? Again, provide HIV education materials and pamphlets, determine a solid process for labs from service operation areas, determine how your insurance billing process for those who are insured, underinsured, and are not insured at all. And then, we encourage you to define the follow-up process if the patient is positive. Surveillance or disease intervention staff. What does that look like in your area? And then lastly, determine your linkage to care process, staffing, and partnership. And this, for negative folks, this can also include linkage to PrEP if need be. And with that, we're going to open it up to Q&A. We want to thank you for your participation this afternoon or morning, depending on where you're dialing in from.
Thank you, Azul and Elizabeth. Can we give them a round of applause? And no people named Ty were hurt in the naming of this village. I want to make that very clear. We did have a question come in earlier.
Sure.
Azul, if you can take down the slide so we can see one another and feel some connection going on here. We had a question come in earlier. The question was, maybe I missed it earlier. Are we talking about rapid test or lab-based test? I think that makes a difference for where the test is offered. And I believe this goes back to the section of the webinar where Elizabeth was reviewing 3 different scenarios or 3 different places or settings where the test could be offered. So the first place was the registration desk, and we reviewed the pros and cons of that. The second location was, what was it, Elizabeth? The waiting room. And then the third one was the treatment room. So when we are talking about those scenarios, the answer to the question that we have, and based upon what we've learned, is that that's mostly doing a rapid test, and that people use the lab-based test as a confirmatory.
Correct. Thank you, Ty.
And what additional questions, colleagues, do we have? There is a lot that we covered. We covered obtaining staff buy-in. Here's a lovely question here. Considering staff turnover in hospitals and urgent care settings, health departments and CBOs, and recommendations on continuity of care regarding opt-out HIV testing in this setting, and the need. Oh, are there any recommendations? Thank you so much, Alicia. Our brother was struggling. Are there any recommendations that we have for referrals and linkages? And I think there are some resources that were shared in the webinar. This webinar will be shared, the recording and the PowerPoints can be shared as well for some recommendations. But Azul and Elizabeth, what additional recommendations would you have when we consider staff turnover and burnout in these locations?
You know, that's something that we saw, especially during the pandemic, just a high amount of turnover in all jurisdictions, whether they're frontier or even urban. And so, you know, what are some recommendations to think about this? It's really building those relationships, you know, ensuring that you have staff longevity. Um, and like I mentioned just a minute ago, really kind of creating those relationships with folks in your community. And that's just not making a phone call. It's breaking bread. It's having lunch with folks and other resources and other clinics and CBOs, and building those partnerships so that when there is staff turnover, for example, in a clinical setting where that's doing the HIV testing, there's some way to offset the balance until those roles are filled again.
Yeah,
Elizabeth, do you have anything to add?
I would echo your comments and, especially echo your comments around staff turnover. And thank you for bringing this up, Alicia, because this is real, right? I mean, there's a survey put out by PH Wins about just burnout in the public health workforce. And I think the survey said around 50%, like 50, half of the folks intend to leave public health within the next 5 years. And like, that's really concerning, right? If we're thinking about so much of this being relationship based. So in addition to relationships, and I always start with relationships in this work, I also think about ways to make this bigger than just one person, right? Because if I am that champion in a small frontier urgent care and I'm into this and like pushing for this because I have this personal connection to this, and then I leave, and others aren't brought in and they're not invited to share their feedback, and they're not hearing the data and they're not hearing the impact of making these linkages to care, then that program might go away when I'm not there, right? So thinking about who can I partner with, who can I work with, maybe they don't share that same personal connection to this work, but how do I make this bigger than just something that I personally feel, motivated to do in the space, to having it be a standard part of process, having it be built into an EHR, having it be just the way that we provide care, that we get to the space where we never remembered doing it different. And that's going to take time. It's going to take time to build this in the beginning. And I think maybe that recommendation is giving yourself grace as you go through this, especially if you are that one person that is pushing for this, recognizing that it will take time to like mobilize others to see the value and to move to action.
Yeah, that's a great point, Elizabeth. And I would even add to that, to really thinking about, we said it, identify a champion, but also that might include who is that champion going to mentor in case something like that does happen. And, with that study with burnout, one of the things we often don't consider is compassion fatigue, meaning that we still want to do the work. We just don't have any more to give. And I think we saw a lot of that, especially during the pandemic. And so thinking about staff resources around burnout and compassion fatigue, and knowing how to identify the difference between the two and getting staff the resources that they need in those situations.
Thank you for that question, Alicia. You were muted. It looked like you said something, but maybe you didn't.
Oh, sorry, I said thank you.
Oh, that's okay. There's no need for sorries. We are not doing sorries today. Nothing is going wrong today. It's a beautiful day. What additional questions? Just want to say that we got a question from Tom. Will the recording of the webinar be available? And yes, we will send out the recording and a PDF of the webinar later this week so that you can share it with those who were unable to attend today.
And I would add at the end of the slides, you're going to have all the resources and cited materials that we used in the creation of this webinar. So if you want to dive a little bit deeper, feel free to do that. And also if you need or considering TA around opt-out HIV testing in ED settings, feel free to reach out to your SIBA provider. That's what we're here for.
There's another question. Are there resources / protocol examples you can share with implementing rapid tests in the ED workflow? We've heard from some EDs that there are concerns that rapid tests may be complicated to add to the provider flow.
Azul, I'm thinking about Ventura County. I know it's not a frontier jurisdiction, but I'm wondering if you could speak to some of that and even what we're doing here in Denver.
Sure. We last fall we worked and did a webinar with Ventura County, and thinking about their flow, and we presented this. I think we have a recording of that webinar as well that we might go ahead and send out with the materials from today's webinar. But the way they're set up, they have 3 hospitals in Ventura County where they're doing opt-out HIV testing in the EDs, and so the test is done by the provider. They've been doing it since, I want to say, 2015. So they've kind of worked out a lot of the kinks, but their process flow is provider goes in, sees patient, conducts the test. The results are given by a nurse practitioner. And then the follow-up, if a test is positive, they have county DIS workers who will follow up with that patient and link them into the appropriate clinic for care. But again, these are things that you're really going to have to play around with. What is going to work best for your clinical setting? Is it having the provider in that situation do it? Is it doing intake? Is it the nurse practitioner? And people will make mistakes, as Ventura shared with us in the beginning, but once you get it down, it is a good flow.
And we can share the protocols for organizations that are using the rapid test in the EDs, because I think that was really specifically the question. Wonderful talk. Do you see CDC or other federal organizations funding opt-out testing more? Would love to see more opportunities for opt-out STI testing. Great question, Amy. Don't know specifically if other federal organizations are going to do more funding. However, CDC was so excited about this webinar because they do want to get the word out regarding opt-out testing in these settings, EDs, and urgent care centers and other clinical organizations. So I wish I had a better answer, but that's what we can share. Next question comes from Alyssa. Do the point of care testing and other tests in ED, do they do point of care testing and other tests in the ED? It could go into the workflow. Another question, HIV affects disproportionately individuals who occupy marginalized positions in society. Are there any plans or recommendations to improve access to care in rural places? Are there lobbying happening to improve these types of resources? Here's a good study about the challenges. So David gives us questions and a resource. David, I love what you are out here doing. Azul or Elizabeth, I'm gonna put a thumbs up with this message. Azul or Elizabeth, are there any thoughts about David's questions and the resource he shared?
Yeah, I mean, my initial thought, thank you for bringing this into the conversation, David. And I think we very quickly touched on some of this in the beginning and thinking through frontier areas and like who is accessing EDs for care because of lack of HIV care in rural places. So we know that there's more work to be done, right? But for the approximately 13% of folks that don't know that they're HIV positive, like some of our work starts in performing those tests, right? And then thinking about what are the opportunities to improve access beyond that. So a lot of it is partnering with state or local health jurisdictions. In terms of lobbying, I don't know that I'm allowed to put on my lobby hat. I can tell you what we're doing here in Denver, but Denver's not a frontier area, right? So thinking about this unique question of rural places, I don't know that I would be able to answer universally. Azul, do you know of specific lobbying efforts?
I don't. I know that Ventura did do a lot of lobbying on their behalf with the state of California to get the cost of tests covered in their kind of rural area. But it's really knowing the systems that you're working with and advocating just by showing them the data, not only the national data, but what you're seeing in your local communities.
If I could just reframe the question. So David, the way I understand the question is, are there any recommendations to improve the access to care So there are rural states that we work with here in the West, and they are all very concerned about what access to care, distance to care looks like in the rural areas. And there have been lots of thoughts around the ways to improve this. What could we do? So this webinar is actually the direct result of a request from one of our rural states, specifically Wyoming, which I think is the home, the real home of the fictional city Tyville, where they were thinking about what does HIV testing in rural settings actually look like. And so there's a lot of work going on in each of the individual rural states or frontier jurisdictions here in the West, where people are creatively trying to think about how to reappropriate funds, how to revision care, how to shorten the distance to care. What could those things be? So to answer that part of the question, yes, and thank you for sharing the study. Would it be okay if we included this study in our PowerPoints as an additional resource for organizations, David? Give us a thumbs up or a thumbs down. Yes, we got an enthusiastic yes. All right.
Yeah, and David, thank you for sharing this resource. I don't think I came across it in my research for today's webinar, but I mean, to your point of, who is disproportionately impacted by this and what does that look like, that should be centered in our conversation. So I look forward to sitting with this. And if you have continued thoughts or want to do a 2.0 on this, Azul and I would love to be in conversation with you about what specifics can look like in your jurisdiction.
Absolutely.
And thank you for bringing up this point of people who are marginalized. Azul and Elizabeth hit on this earlier in the webinar. We at the Denver Prevention Training Center really see our jobs as to really help amplify those voices of those who are overlooked, those who are marginalized, those who are on the blunt end of society's messed up paradigm of only caring about those who are in the dominant groups. So one of the things that we wanted to cover in this webinar is understanding that there are groups of people who are accessing emergency departments and urgent care centers because that is how they get their health care. That is their only option to get their health care, and for numerous reasons. So thank you for doing that. Comment is that many counties across the US are really working on moving access to care to rural, and we really want to get this in people's minds, frontier communities and exurbs, how we understand. Azul, can you go back to that PowerPoint where you had I think it's 5 or 6, where you had the map of the country in frontier in green? I think we really want people to understand that we're not just talking about a rural community. The definition between rural and frontier, sometimes people use those interchangeably, but they are really drastically different. When we are looking at this map that Azul is pulling up, and thank you for doing this, Azul, all these areas in green, which is really the part of the country that the Denver Prevention Training Center is working on, and look at all of Alaska is in this green. These are areas where the population density is so different than in rural communities. So we're talking about people who are often overlooked when it comes to care, because people just think of rural as really what is out there, but there's something beyond rural. It's this frontier and remote that we are really thinking about. Those are the people who have a hard time really accessing care for a number of reasons. So we just really want people to understand that we're not just talking about rural or the exurbs. We're talking about areas where you have to go down the mountain and it takes a couple of days to get down there, a couple of hours. That distance to care is 3 to 4 hours. I think that's what you cited as part of the definition, right, Azul, to actually get an access.
Correct. Yeah.
We're really trying to get people to change their paradigm of who is in these communities, because people who are in these communities look like everybody on the phone. They have on the Zoom, they have different levels of resources and things like that. Thank you, Azul, for being able to get that PowerPoint up there. What additional questions, comments do we have in our remaining 5 minutes? Well, thank you all for joining today. It is a day to go outside and connect your body to the grass, reset your nervous systems, drink some water, love on yourself and love somebody else. Have a great day, colleagues.
Thank you, everyone.
Thank you.